cholesterol. In deference to what we just did with hypertension, which is we deputized all of us as equal deputies, and we looked at the evidence-based. There's far more evidence-based medicine in the cholesterol world than I think we need to go over. So I suspect that the better way to approach these guidelines, but the concepts are the same. As you're going to see, the guidelines were developed on the exact same premises as JNC8, and that's going to be the beauty, I think, of future guidelines, is they were based exactly the same in terms of the critical questions and evidence-based medicine. But I suspect on this one, let's just look at the recommendations. We can talk about some of the data to back them up, but I would rather prefer us try a discussion around the recommendations because, in fact, they're even more dramatically changed than the hypertension recommendations, even though they were changed in those nuances that we looked at more closely just several minutes ago. Let's talk about the cholesterol guidelines. Well, the American College of Cardiology and the American Heart Association did develop these set of guidelines, and they will now develop the hypertension set of guidelines. These two organizations have now taken charge of obviously the guideline development. And they were recently published in December of last year, and they've now been widely disseminated. It says 2013, but it's still within 12 months, and it was just barely in 2013. Same charge. The NHLBI, who made the call for the guideline development, in addition to, to build on our ATP guidelines of the past, asked the committee to look at randomized clinical trials, evidence-based medicine, as much as possible, to look at pharmacologic lowering of cholesterol and cardiovascular outcomes, and also ask, pick 3 critical questions. And let's start a discussion of where we are in 2013, now 2014. They developed 3 critical questions, just like the JNC8. There were other committees that I'd like to bring to your attention that you can look at, but we won't discuss this morning. And that is, there was a risk assessment work group, and there was a lifestyle management work group as well. Well, let's just go right to the chase. What were the 3 questions that the cholesterol guideline group, expert panel developed, and what are the answers? Question number 1 was, can we use LDL or non-HDL cholesterol as titration guidelines for secondary prevention of cardiovascular disease or atherosclerotic cardiovascular disease? That was the first critical question. So in other words, secondary prevention, are there goals? Are there targets? Again, what's how low are we going to go? And if so, is there titratability of the LDL cholesterol commensurate with pharmacologic therapy and reduction? What's the evidence? Bottom line, there is no evidence-based medicine to support titration, guided titration, if you will, of the LDL cholesterol or the non-HDL cholesterol for cardiovascular outcomes. That was interesting, because obviously that's what all of us were doing. But there is strong evidence-based medicine for the intensity of the pharmacologic therapy. And the trials did not look at titration of the LDL cholesterol, but they were robust enough to look at the intensity of the statin, the dose of the statin, if you will, moderate intensity versus high intensity. And LDL titration is somewhat, of course, correlated with the dose of the statin, but not specifically titratable, if you will. That's a huge change for all of us. So rather than looking at the LDL target or LDL targets or titration, now actually simplifies our therapy in certain respects. There's moderate intensity of the statin, and there's high intensity of the statin, and there's recommendations based on intensity, not the titratability of the LDL cholesterol. That was for secondary prevention. What about primary prevention? Same thing. They looked at 6 well-done, valid, randomized controlled trials. And similar to secondary prevention, they concluded that, again, there is no evidence-based medicine to support titrating the LDL cholesterol to a certain goal for primary cardiovascular prevention, but there is evidence-based medicine to dictate the intensity of our statin therapy based on the agent and based on the dose. And we're going to discuss that further. That was question number 2. Well, what was question number 3? What did the JNC8? Question number 3 is, which car are we going to drive? Well, they came up with the exact same question. Which car are we going to drive? Or are certain pharmacologic lipid-lowering drugs better, more appropriate than others? And that's question number 3. So in populations that were examined, were adults without heart disease or cerebrovascular coronary vascular disease for primary prevention. They looked at all the agents, all the cars you possibly could drive today. And there may be new cars in the future, but we don't know what they are. They looked at efficacy and safety. And they concluded, bottom line, given the safety and the efficacy profile of the statins, they are our primary pharmacologic agent to employ. Doesn't mean we can't employ the other agents in combination, et cetera, when appropriate. And we can discuss a little bit about that. But the car we're going to drive, there's one model. And that's the statins. And that was the answer to question number 3. So, they went further. If you can't titrate, if there's not evidence-based medicine to support titrating the LDL cholesterol to a goal, but there's evidence for intensity of the statin and the dose and the individual statin, then what are we going to do? Who are we going to treat? And what intensity of statins are we going to treat with? So that opened up other cans of worms, which they deliberated about and gave us recommendations. So for the first time, they broke it down into populations where evidence-based medicine has been shown to benefit cardiovascular outcomes with statin therapy. And the 4 groups, as you already are well aware of, are shown here on this slide. Patients, of course, with known atherosclerotic cardiovascular disease. Secondary prevention. Known. Check. Done. We'll talk about intensity, how, when, etc., but yes, that's one group. Individuals with extremely high LDL concentrations. LDL concentrations of 190 or greater. Even without secondary causes, but without known cardiovascular disease, because they're at significant increased risk. And these are our familial hypercholesterolemias, our heterozygotes, our combined dyslipidemia patients. But significant elevation in LDL cholesterol, 190 or greater, check. Yes, we should be treating these individuals. Primary prevention are diabetics. And our diabetics within a certain age group, which the evidence-based medicine supports. And again, even with lower LDLs, even down to 70. If you're diabetic, you're in. And the last group, of course, was for primary prevention. Without diabetes, without, obviously, atherosclerotic cardiovascular disease, etc. If you have a 10-year adjusted cardiovascular risk of greater than 7.5, and there's a new calculator for that we're all going to get out our little smartphones, and we're going to either make sure we have it on there, or we're going to put it on there today, for a risk of greater than 7.5 over 10 years. For primary prevention, those are our 4 groups. Simple. We all know them. Right? Got it. Here's the risk calculator. Anybody want to get out their smartphone? I turned mine off, but I already have mine on it. If you want to turn your smartphone on now, and you promise me it's not going to ring, buzz, dance, or whatever, sing, put this on. The free app is ASCVD risk. So just go to your apps, type in on your search, it's on the American Heart website, but you can do it right now, ASCVD risk. It'll pop up, and just install. You're done. All of us have to have this app. Because it's going to be, obviously, if we're going to follow guidelines, we need it. So there it is. I'll just leave it up for a second or two. And now you're going to see that you can start playing with it. You can put all kinds of things in there. You could put age. You could put blood pressure. You can put yes or no smoking. You could put white or African American, etc. And just stick it on there. Joan, did you have a question?
So that calculator does not work for the elderly?
Yes. We're going to talk about that. Well, it works for the elderly, but it's controversial. Joan. And what Joan's alluding to is that as you get older, it's going to throw everybody into that risk category. We'll talk a little bit about that, Joan.
Actually, the calculator
Does it? It's,
it doesn't apply to any.
yeah, because of the age group, because of the evidence-based medicine. If it did, though, Joan, I can assure you, everyone would be greater than 7.5 risk. Right? If you wake up elderly, you're at. And thank you, we're all here. We all woke up. Yeah. Remember, 1 day older for every day you live is the definition. So anyway, if you don't want to put it on now, fine. Write it down. You already have it on there. We can talk about the calculator more, because there was some controversy around the calculator. Okay, so the scope of the guidelines were, as we've already said, they're emphasizing treatment groups. They are still recommending, of course, non-pharmacologic lifestyle modification, and they identified those 4 specific treatment groups. They did mention the all others, but it's going to really be up to us. That's the art, the intuition, and expert opinion. And that's a significant component of medicine, as we all know, including even in JNC8. Half of it was expert opinion. The new perspective was, of course, there's lack of randomized clinical trials to support drug titration, which is really going to be different for us. At least it's different for me, because that's sort of been my modus operandi. I just want to keep checking that LDL, and I want to keep driving it down. Well, we don't need to do that anymore, versus except for, in certain situations, high versus low intensity, and to make sure that we did achieve a goal. And why? Why do they come up with these recommendations? And as you can see, the randomized data does not indicate what target, because they just weren't done. They weren't target-driven. They were statin and dose-driven. Other things is we don't know the magnitude of the risk reduction, like we did in that HOT trial. For graded differences of blood pressure, we knew exactly the reduction in cardiovascular risk in those 18,000 individuals. We don't have that type of data, that type of evidence-based medicine for our hypercholesterolemic patients. And again, these are the 4 groups. They're in your handouts. They're on the CD. And please, this is right from the American Heart Association and the publications. Duplicate them, put them wherever you want to put them. But they're there for your uses. And again, here's one of the initial logarithms. We're not going to go through all of the algorithms this morning, because they can get a little bit more complicated, but this is probably good enough. And again, there's going to be our 4 groups. If you have atherosclerotic cardiovascular disease, and it's yes, you're less than 75, moderate intensity. And if you're greater than 75, high intensity, and then moderate intensity if you're greater than 75. If you wish to use high-intensity statin therapy in that population too, that's the art of medicine. And we're going to talk about what moderate and high intensity is in a minute. If your LDL is greater than 90, yes, high-intensity statin, go right to the top, because we know that they're at such risk unless they can't tolerate maximal doses. If you have diabetes, just like, don't pass go, don't collect $200, and it's yes, moderate intensity, high intensity if you're greater than 7.5%. Cardiovascular risk on that calculator. And the last group is going to be primary prevention. Oops. And there it is. So if your estimated 10-year cardiovascular risk, if you're greater than 7.5, moderate to high intensity, no, still continue to do good health, do good things. If there's other confounders, et cetera, and you want to start lipid-lowering agents, again, that's the art, that's the intuition, that's that's expert opinion. On the other hand, it's really based on the risk calculator. So now let's talk about the risk calculator. It's new. It uses new versus our old one, like the Framingham risk calculators, et cetera. This one used newer data. It used larger pools, and it used greater subsets of individuals in the risk calculation. To my thinking and my reading of the controversy and the opinions in the New England Journal of Medicine and JAMA, et cetera, and also using it, my feeling is that it's actually better, it's new and improved for the high-risk patients. It more adequately addresses the high-risk patient. But as Joan also mentioned, it may overestimate the risk of the low-risk patients. And it may tend to have us place more patients on statin therapy, moderate intensity or high intensity, than we would have in the past. So if anything, it might be overestimating the low-risk group. But I think it's probably new and improved and a better estimation of our high-risk cardiovascular patients. And there's a trade-off in any risk calculator, but I want you to be aware of that. And if you play with it, you'll see what I mean. If you just raise the age a little bit and don't change anything else, it might throw you into the treatment, category, et cetera, where otherwise you would have went, that doesn't feel right. That doesn't pass the smell test. But again, it's a calculator, and it's for our use, and we can choose how to use it and how to use it best with our individual patient in our individual exam room. Intensity. So what is this moderate and high intensity stuff? You can just take this right off and print it. Because it depends on the agent, and it depends on the dose. Moderate intensity we can look at first. First of all, there's no such thing as low intensity statin in the guidelines, so that's just for information as to what it would be. Moderate intensity, you can see most of the statins would fit in the moderate intensity with that dosing regimen. And the goal of moderate intensity is that the targets that were achieved was about a 30% reduction from baseline LDL. So the definition of moderate intensity is reducing LDL cholesterol, baseline LDL cholesterol by 30% or greater. High intensity, the definition was a reduction of LDL from baseline of greater than 50%. And as you can see that, evidence-based medicine supports only two, atorvastatin and rosuvastatin in the doses that you see. And again, there's a range of high-intensity doses. You can maximize these doses, but at minimum, the initial doses for high-intensity atorvastatin and rosuvastatin are there for your leisure and your review. So that's it. That's pretty straightforward. And if you want to just use rosuvastatin and atorvastatin for simplicity, keep it simple, then you can just change the dose from 10-ish, 5 and 10, maybe 10 and 20, to the 40 to 80 and the 20 to 40. Or you can have your pleasure of the other statins as well. These are in your handout. These are more specific now for each of the groups, but I do not believe we have to go through them this morning. But I just wanted you to be aware that they're here, and they're a little more detailed for each of the individual 4 groups. This is the example for clinical atherosclerotic cardiovascular disease, but it's for your pleasure. And again, you all have it for you. And if you do not have it, I can get it for you. Just ask Mandy or myself, and we will furnish these for you. This continues. This is now for primary prevention, LDL cholesterols of greater than 190. Then there's going to be for diabetes, and then primary prevention. So those 4 groups are there for you. So what's new? We now have a new risk calculator, which estimates a different pool of 10-year atherosclerotic cardiovascular risk. It's more inclusive in that it now has gender, and it now has at least 2 races. It has Caucasians and African American or a black population, which is, I believe, a significant advance. It more accurately identifies, as I said, the high-risk patient. It may denotate or pick the low-risk patient. You may overemphasize that patient, but again, if it doesn't pass the smell test, that's what we're there for in the individual patient in our individual examining room. But be aware. What about individuals that are not in these statin or these 4 groups that have not demonstrated statins? Here are some of them that they considered. And they looked to see, is there evidence-based medicine to support? What if you have a premature history of atherosclerotic disease, but you don't fall into any of those 4 groups? Should we treat you? There's not evidence-based medicine to do so. What if you have a high LDL of 160? What's magic about 190? Well, the evidence-based medicine is the magic. What about 162? What about 187? Well, that's where you only can take the evidence-based medicine only takes you so far. What about high C-reactive proteins, inflammation, et cetera, and blah, 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 blah. Yeah. ABIs or even calcium, coronary calcium scoring. And really the recommendation is these are cardiovascular risks, and This is where the evidence-based medicine takes us down the field, but may not cross the goal line, yes or no, in these categories. And remember, lack of evidence doesn't mean lack of efficacy. It just means we don't know. They also did go into, since this was a major concern, and a lot of the frequently asked questions to the panel from their focus groups was, well, what about symptoms of the statins? If we're only recommending this one group, wow, now what? Especially because we know, of course, of the muscle and symptomatology and the rhabdomyolysis associated with statins, although rare. Well, if there's severe symptoms of muscle cramps, etc., of course, you're going to evaluate those symptoms. You're going to look for secondary causes. If it's severe, the recommendation is discontinue the statin immediately. Whatever severe is, it's in there. There's some descriptions of severe, but you know it when you see it. But if there's severe unexplained myopathy or muscle tenderness, muscle soreness, stop the statin and significantly then search for rhabdomyolysis with our clinical parameters. And then if found, obviously exclude secondary causes, but immediately stop the statin. And obviously probably should never not use a statin again. That'll be problematic, but this is severe rhabdomyolysis. Statin, documented rhabdomyolysis, severe symptomatology. Cease and desist. But that's not what usually happens. What usually happens in the patients that I see is aches and pains, and they're on a statin. Either yesterday I put them on it, or 2 years ago I put them on it, but again, it's like the Fram oil commercial. It's pay me now or pay me later, but it's going to happen. They're going to walk in and they're going to say, it's my statin, Dr. DePetti. If it's mild to moderate symptoms, most of the time this turns out not to be associated with statin therapy, but never say never. So what's the recommendation? Discontinue the statin, but now not forever. Evaluate the symptomatology, look for secondary causes, and they're listed there for you. We all know them, but just for a reminder, they're on the bottom. But after a couple months, if the statin's been removed, the symptomatology doesn't abate, and or you can explain it with a secondary cause, you treat that secondary cause, then you can restart the statin. And you can then safely restart the statin and start over. Obviously, if severe symptomatology, discontinue it and revisit the statin therapy because they're so critical. If they're going to be our foundation, it's a critical piece of therapy in our management. Okay. Use the maximal intensity statin that's tolerated in the niche of those 4 groups, if you will. And again, you have to assess at least the efficacy of the response. If you're moderate, repeat the LDL cholesterol for 2 reasons. Number 1, to make sure you hit the target. If it's moderate, less than 30%. If it's high intensity, less than 50%. And also they recommend rechecking the LDL cholesterol for compliance. Is the patient taking the medication at all? That's, again, up to all of us. And I don't need to tell you guys about compliance. And again, what about the other drugs? What about the non-statins? If you can't use primary statin therapy for whatever reason, severe symptomatology, allergic reactions or whatever, yes, use other classes of cholesterol-lowering agents, but use the classes that have evidence-based medicine, like bile acid sequestrants from the old LRC trial, gemfibrozil from the Helsinki heart trial. They're not as effective as statin therapy, but they're obviously our fallback positions. So let's summarize. The cholesterol guidelines really did dramatically change the way we approach hypercholesterolemia, divided the groups now, the target groups, into 4 specific groups, not necessarily based on either the starting point of the LDL cholesterol, except in group 2 with 190, and also with the guidance that there's no there's no sense or no rationale for titrability of LDL cholesterol, but there is evidence, of course, for intensity of statins. Similar to our other guidelines, however, they're different and they're changed, and we're not used to them. We're used to compendiums, we're used to book chapters, we're used to want to know everything you wanted to know about hypercholesterolemia, but we're afraid to ask. Well, that's not what the new guidelines are going to be out there to do. That's what review articles are for, book chapters, etc. They challenge our current thinking. I think the cholesterol guidelines challenge our thinking even more than the hypertension guidelines, but they both do so. And it really puts greater, I think more appropriately, we're talking about personalization of medicine. It's sort of moving in that direction, although this isn't a genotype and a therapy. It's getting closer to taking the characteristics of that individual patient that's in our office, in private with us, and trying to make more sense of the individual patient, their situation, circumstances, et cetera, risk factors, race, sex, and age, in both of the guidelines, in both the hypertension and the hypercholesterolemia guidelines. And I think that's a positive move, I think, in the right direction. We may stumble along the way. We may change as we reevaluate, but I think it's a worthwhile and it's a valuable new journey. Thank you very, very much for having me. I knew we would have more time after the cholesterol guidelines because I did not want to get into the weeds and look at all those studies. So if we want to revisit the hypertension guidelines as well, please, I'll just throw it out and ask me anything you want to know, and I'll say I don't know if I don't.
If you have questions, let's see, go ahead. Come to the microphone in the middle.
Or other issues about hypertension or anything that we're worrying about or losing sleep over. Yes.
Well, as a practicing general internist, I appreciate your passion
Thank
for
you.
this because I've shared it for years. I think our prevention of cardiac morbidity and mortality has been one of the most important things we can do for our patients, and especially the cholesterol treatment. I've been doing the secondary prevention for years with the high-dose statins. The evidence has been really strong for some years. The big question is coronary artery calcium scoring. I've been using that for some years. I've even just looking at CAT scans on patients, looking for clinical, subclinical atherosclerosis. To me, the evidence probably leans towards treating that as if they really have clinical atherosclerosis.
Certainly, we know that the association is real. The higher your calcium, your coronary calcium score, the more likely you are to have, known cardiovascular disease and/or future cardiovascular. That's clear.
Especially the cost effectiveness of coronary calcium scoring. It's inexpensive, minimally invasive. I mean,
it's got all good stuff.
Great information on patients. Been using it for several years, and I think it's really something we probably should do more of, just because of the ease of getting it. Unfortunately, insurance companies don't pay for it very well. Sure. But the cost is anywhere from $75 to $200 per patient.
We've made it relatively affordable now. The problem, though, is I can dream about these things at night. I can go to bed or wake up at 3 in the morning and have this fantasy dream that we did a huge randomized clinical trial, and we took people with coronary calcium scores of 100. Coronary calcium was 300 and 600 or whatever, and we treated them, and we looked at the outcomes, and we saw whatever we don't have that data. That's the issue, and that's what the committee, that's what they angst about. Same thing with HRP or whatever other biomarkers we want to use. We just don't have the data.
But like sending patients to patients has a coronary artery calcium score of 400 plus. You send them to you do a stress test on them. It's positive. Sure. They have clinical disease at that.
No, that's different. If you use it for that,
they had disease before
absolutely.
You did the stress test.
Sure.
And so it's the same population.
Sure.
If you were to look at it.
Absolutely. That's the other way to look at it. Okay, it's a biomarker, or it's a physiologic marker, a pathophysiologic marker. Then if you want to do the intense, a workup for that disease state and you find it, well, now they're in a different category. They're in the known atherosclerotic cardiovascular category, and you treat them.
But they were in the same category before you did the workup.
Yep. But what if they were negative?
But it's pretty rare to have a greater than 400 calcium score if they say,
a little bit of here and a little bit of there.
It's rare. Let me put this. It's not common. It's more often they have disease. I mean, on average. I haven't seen one yet. At least it didn't. But I guess there are some.
There are some that have subclinical that we don't know what the significance of the disease is. 20% here and 30% there.
And there's one study that looked at treatment of stenosis in people that angioplasty versus aggressive lipids, 60% blockage. They had actually the people who treated with intensive statins did better than people who got angioplasty. So there's a lot of evidence that obviously statins do a really good job.
And that's why they're the cornerstone. They appreciate it very, very much and understand the angst.
We have another question. There we go.
This is just my ignorance of the guidelines.
Oh, you and me both.
if they're diabetic and they don't have a 7.5% risk and their LDL is less than 70, then you would not treat them with a statin.
I find it hard to believe that the risk calculator a diabetic would not be less than 7.5.
Right.
I'd have to do some manipulations to see if that was possible, but I think it's already going to put you into the category.
But if it did,
then it's just doing the intensity of the statin.
And if you calculate them and it's greater than 7.5%, rather than moderate intensity, you go
High
with
intensity.
High okay.
Yes. Yeah. But all diabetics, at least, you're already in if you have diabetes. Then it's just a matter of moderate or high. And most of us probably would treat, if they tolerate the statin, most of us would treat with high intensity.
Next question.
Isn't it possible that the easiest way to analyze the patient is send them to get a life insurance policy? and then they're going to...
They already know. Yeah. Trust me, they already know the data. What's really, I'll digress, but what's really interesting is the life insurance companies way back to 1915 were already taking blood pressures on everybody, whereas we weren't doing that in the office because we didn't know what to do with them, quite frankly. And they were already adjusting policies unbeknownst. And then when they actually, in 1920s, 25, 30s, they actually became more transparent, and the medical community actually rebelled against the practice, saying that's not evidence-based, medicine. There's no evidence, and blah blah, And then there was this tug of war back and forth. As recently as 1930s, 1940s, prominent American and British physicians were saying only a fool would lower the blood pressure. That's actually a quote. Wow. But anyway, that's why we continue to progress and be inquisitive and ask questions and do studies, because times change.
Do we have any more questions for Dr. DePetty? Okay.
Thank you very much for having me.
Let's give him a round of applause. We're going to take a short break here, and we'll reconvene promptly at 9:15. I encourage you to visit the hospitality area across the hall in Magnolia D, E, and F.